I am glad to be here presenting my experience after seeing 10,000 EDS-HSD patients in the last 25 years. Hypermobility EDS-HSD appears to affect about 39% of the world's population and is rarely diagnosed. They have cracking joints, arthralgias, and history of sprained ankles, tendinitis, ruptured tendons, etc. Hypermobility Ehlers-Danlos is not a condition. It is a dominant inherited disease. When studying a patient for the EDS, look for the family history of hypermobility and dysautonomia. Patients have arthralgias. They do not have arthritis. A patient that has arthritis has two diseases. The Baton score is very useful to determine the degree of hypermobility. My impression is that people with fibromyalgia really have EDSH or HSD with or without dysautonomia. The differential diagnosis between pelvis spondyloarthritis and EDSH HSD is difficult. Young patients have diseases of the elderly. They usually have early osteoarthritis, hernias, varicose veins, spinal disc disease, osteoporosis, etc. Physicians should be able to differentiate the typical EDSH phases from the vascular type EDS phases. Here, we see pictures of these two conditions. I can see very clearly the difference. In EDSH, these patients have light complexion, they have triangular face, they have occasionally light blue sclera and occasional anti-Mongolic slant, but they usually have atypical ears and atypical nose. On the other hand, the EDS vascular type patients look like tired, they have sunken eyes, haggard eyes, triangular face on occasions, lack of adipose tissue, and a thin upper lip, which is not characteristic. TMJ problems are frequent. Treatment by a specialist is important. Young people with spinal disc disease most likely have EDSH. In my studies, osteopenia and osteoporosis is seen in 10% of EDSH patients below the age of 30, so it's quite frequent in young people. In our studies, 15% of EDSH cases were associated with rheumatoid arthritis. In EDS, cysts are seen in many organs. I think that polycystic ovary could probably be part of this disease as well. Nowadays, many patients are cataloged as being part of the hypermobility spectrum disorder, but to me, EDSH is still more prevalent. EDSH HSD patients are very allergic, and frequently they have asthma or allergic rhinitis. In some cases, they can have mast cell activation syndrome. I have a list of slides when to suspect these patients. You can see that in my webpage, www.rheumatologia.drbravo.cl, or my book, Ehlers-Danlos Hipermovible, Dysautonomia and Fibromyalgia. A good way to suspect the EDSH-HSD diagnosis is to observe the hands of this person. Here you can see the hand of the hypermobile scribe, which I described for the first time in this year 2012. It is very characteristic and is typical of hypermobility. Other signs that usually help by looking at the hands is the flying bird hand sign, the sign of the horizontal thumb, and the extension of the fifth finger up to 90 degrees. I tell obese patients that they are like a truck with a very big load and with poor quality tires and with misaligned wheels in case they have genu recurvatum. They will develop osteoarthritis of the knees, and if they don't lose weight, they have developed osteoarthritis. Since the hypermobile patients are so frequent, the diagnosis of EDSH-HSD and dysautonomia should be suspected in any patient that has arthralgias and fatigue. Marfanoids are usually tall people with long extremities, big feet, and usually have square shoulders and prominent ribs. They may or may not have pectus excavatum or carinatum. Marfanoids comprise 15% of the EDSH-HSD. As you can see the Marfanoid habitus in Ehlers-Danlos Hipermovible and in Marfan syndrome. And this is important to make the differentiation since Marfan syndrome may have more frequently arterial problems. Here you can see two siblings with Ehlers-Danlos Hipermovible type and a father and the sons with Marfan syndrome. This picture was taken from the literature. Our studies have shown that many EDSH patients look younger than their biological age. EDSH-HSD patients may be clumsy because they lack proprioception. They may also have resistance to local anesthetics. Since hypermobility decreases with age, Hakim and Graham's 5-question questionnaire is useful to diagnose hypermobility in older people. Lenticular moles are useful to suspect the diagnosis as well. Here you can see the lenticular moles. As you see, they are like little lentils. In the Hakim and Graham questionnaire, with 2 positive answers, you can realize that the patient most likely has had hypermobility. This question, for example, can be, can you now or before touch your forearm with your thumb, or do you ever had double joints, or as a young person, did you amuse your relatives or friends by doing some contortionism? The diagnosis of dysautonomia is clinical. The tilt test should never be done, since it can produce severe arrhythmias. We know of 8 cases of cardiac arrest. About 80% of EDS have dysautonomia in our studies. POTS, postural orthostatic tachycardia, is frequently seen in association to low blood pressure. I prefer to treat the hypotension first and later start with a low dose of a beta blocker. How to relate hypermobility, Ehlers-Danlos, with dysautonomia? The answer is related to the weak collagen these patients have. The weak collagen develops dilation of the wall arteries, causing low blood pressure, which reduces cerebral oxygen perfusion, causing dysautonomic symptoms. Cracking joints do no harm, but they alert towards the diagnosis of EDSH-HSD. The absence of hypermobility, Ehlers-Danlos, does not rule out dysautonomia, since in our studies of 2,300 patients with dysautonomia, 51% of them had no noticeable hypermobility. On the other hand, everybody with dysautonomia has to have EDS because they need to have abnormal collagen. In some cases, the patient has dysautonomic symptoms and also has hypertension, making the treatment quite difficult. Later, with true hypertension, dysautonomia disappears. The diagnosis and treatment of EDS and dysautonomia should start in childhood. I tell patients that dysautonomia treatment is very much like the treatment of diabetes. It needs to be very well done and for life and must be followed by a physician. When to suspect EDS in children, this is so important to do so at an early age. Hypotonic children, they start to walk late after 12 months. Usually they do not crawl. Hip dysplasia, joint hypermobility, cracking joints. Hyperactive children, they have attention deficit and dysautonomia. Typical EDS phases or some of the signs. lack of lingual frenulum, mobile tongue, family history of EDS, and later the possibility of scoliosis. There is a tremendous worldwide need for EDS and dysautonomia specialists. Dissemination of information about these diseases is imperative. We need not only to help the help of all health personnel, but also from teachers, politicians, public in general, especially the media. Here I have pictures of my book that now is in 3 languages, Spanish, English, and Portuguese. It is available through Amazon. Details of the book may be found in my webpage.